I think in the treatment of ALL, especially adult ALL, we have made a lot of advances recently, and it was mostly related to intensification of standard chemotherapy, taking some lessons from the pediatric advances obtained by increasingly using more intensive chemotherapy in these patients, the children actually. So that was the first big advance. And the second one was for the Philadelphia chromosome positive ALL. In the beginning of let's say 2000, the early years, we used TKI in this patient. First imatinib and then second and third generation TKI. And it contributed significantly to advances in this poor risk, initially poor risk of adult ALL, very rare in children, but very frequent in older adults. So this has been the two major advances. And now we are experiencing a new era with new agents and essentially immunotherapy, whatever you call immunotherapy. It could be antibodies, simply antibody, like rituximab in CD20 positive patients. We published a study showing that addition of rituximab in these, let's say, 30 to 40% of patients who express the antigen, the CD20, significantly benefited from the addition of rituximab. So that could be antibody. That could be targeted treatment, new targeted treatment. I mentioned TKI in Ph positive, but we have some other fields for investigation using TKI in Ph-like, which is a newly subgroup of poor risk ALL, frequent in adults. And we can use also targeted treatment in early T-cell precursor ALL, which frequently also harbor mutation of several types of tyrosine kinase. So that is interesting, and we will do that certainly in the next year. And the most impressive results have been recently obtained by either antibody drug conjugates, inotuzumab ozogamicin compound with very impressive results in relapsed patients, and also with the BiTE, the blinatumomab compound, with similarly impressive results in relapsed and refractory patients. So the next field are to move all these drugs into frontline treatment, maybe not only in high-risk patients, but first in high-risk patients. But we can also make some advances in standard risk and eventually in good risk patients, because survival of good risk patients is still around 80%. So there is room for further advances. And finally, progresses in transplantation and CAR T-cells technology will certainly offer new options for more advances. I'm thinking about haplotransplant, which has been discussed during this meeting, which is a very interesting way to transplant the patients, and obviously on CAR T-cell technology. So probably haplotransplant, or let's say transplantation in general, and CAR T-cells will be restricted to high-risk patients, firstly because of toxicities associated with these procedures. But you see there is a large panel of investigation now, and maybe there will not be enough patients to do all these investigations together. So we need collaboration, and we need to not do exactly the same trial in one group as compared to other group in order to investigate all these different possibilities of new treatments in ALL patients. It's raising very, very important issues, and it will be very difficult to answer these issues because of the rarity of the patient subset. It has been done in Ph positive ALL because Ph positive is relatively frequent, and because we had and we still have very effective drugs, the TKIs, again, BCR-ABL. And what we observe in our group in France is that when you have a new targeted treatment, like let's say imatinib, first in Ph positive patients, we can revisit your backbone of chemotherapy, and you can significantly reduce the intensity of chemotherapy. And eventually you can maybe reduce the use of stem cell transplantation in this patient. So depending on the efficacy of your targeted treatment, you can probably balance the use of new targeted treatment with the use of intensive chemotherapy to find a way to have the less toxic and the more efficient combination. So this is an important consideration. The other one is that it's not because you are diagnosing a mutation in one individual patient that the targeted treatment will be really will represent a benefit for one given patient. So it will be difficult to evaluate the real efficacy of new targeted treatments in very, very small subsets because of the lack of patients and the lack of control group. And we cannot imagine to do a randomized trial in a subgroup which represent only, let's say, 1% of all ALL patients. So it has to, we have to think about new trials, new endpoints, new ways to prove that the targeted inhibitor is really effective, yes or no, because we are using this usually in combination with chemotherapy. So which is effective? The inhibitor of the chemotherapy. So it will be a real issue. My fear is that everybody will use targeted treatment without evaluating targeting treatment, because all these drugs will be relatively expensive. So we have to prove that it's really a benefit. So my fear is that personalized therapy will be also isolated therapies in one center for one patient without communicating, without trying to evaluate really the result of this targeted individualized treatments. But okay, it will be very difficult. I mentioned the difficulty to work on subgroup of patients. Let's see, for instance, in AML, the midostaurin trial, midostaurin targeting a relatively frequent subgroup of AML patients, 30 to 40% of AML patients, which represent a large subgroup of patients. It took 12 years to do the trial, the randomized trial, and to definitely prove that the addition of midostaurin is beneficial. We did a rituximab, I mentioned a rituximab study in CD20 positive ALL. It took 10 years to do the randomized trial, analyze the result, and publish that the addition of rituximab is beneficial. So you see what I mean? And this is relatively frequent subgroup. So how to do that if the subgroup is only 1%, as I mentioned? So I think that the next years, the work will be to introduce new treatment into frontline therapy, because usually all new treatments are developed and registered for advanced patients or older patients in AML, for instance. But okay, patients with relapsed refractory disease. And it's not enough for us, doctors. We have to use this efficient drug to treat all the patients, not waiting the relapse, but preventing the relapse by using these agents. So this is what we have to do. This is the academic work. This is our task to do that. And the second point, also important with respect to immunotherapies, is the use of these strategies in maintenance. ALL is one of the few diseases, there are other diseases, but okay, is one of the few acute diseases where a maintenance treatment has been approved as beneficial. And it was based on chemotherapy coming from the pediatric ALL works and results. And now we can revisit the maintenance phase of the treatment by using immune interventions like antibodies, blinatumomab, and others.